Morning. Morning, everyone. I hope you're all good. Had a good Christmas break. We're back, last one of 2025. It's weird. I keep on thinking uh, everything in relation to something that happened last year, and we're still in last year. We're not quite there yet. So welcome back. We've got hip pelvis, nerves and blood supply today. I think we might have to do another one. We'll see how we go. Morning, last one, 2025. Yeah, it's been really good. Thank you. Thank you, David. Well done. Say consistency is a good thing. Maybe not in that respect. But no, I know exactly what you mean. This morning was, even though it's 10 o'clock start, it was a difficult one to get up for today. Right, let's get you going. This is where we finished. Nothing quite like dusting off those Christmas drink cobwebs by talking about the perforating cutaneous nerve. Yay! Okay, so we left when we were looking at sciatic nerve and the fact that the sciatic nerve doesn't supply skin sensation to the back of the thigh. It's other nerves that does that, and this is an exploration into those. The skin nerves are called cutaneous nerves. The annoying thing is that it's very difficult to get cadaveric images of cutaneous nerves because they are very fragile, and in the endeavour to reach the connective tissue and the muscles underneath, in the past, anatomists have just gone straight through that skin layer, straight down to those layers, and completely missed the cutaneous nerve. So it's one of the things. Tristan came on a dissection lab with me the other day, and that was one of our main focuses, was to look at those cutaneous nerves and how they come through from the deeper layers and then come up into the bottom part of the skin. And one of the ways that they're described is a bit like a tree. So the cutaneous nerves are like the leaves on a tree, and that's pretty much what they look like. They kind of come up and then spread out on the undersurface of the skin, and you can see the layers of the all of the nerves in that skin layer. So that's but yet, like I said, I have tried searching the internet for images, and it's really difficult. And we have strict laws in the UK around taking photos of bodies in anatomy labs. And I know there are some videos from the States. There's another YouTube channel that show you dissections. I wish I could do that in the UK, but unfortunately, because of well, it's unfortunate in a way, but obviously we need to respect the people that are donating their bodies as well. So yeah, it's we miss some parts of what we see in the labs because we're not allowed to take pictures and display them. So we have to make do with kind of like use your imagination a bit, or come to the labs with me. It's usually in December in London, so we've got a whole year if you want to come along next year. So perforating cutaneous nerve, here we go. So this is the sensation to the medial and inferior buttock, so around this kind of area here, and then we've got posterior cutaneous nerve coming down here as well. So this whole kind of middle section of where the hamstrings are really, and so this is it's not anyway. So it's really important to kind of differentiate between what this is, which is a cutaneous nerve field. So this particular nerve supplies this region of skin, and a dermatome, which is coming from a specific nerve root. And that, if there's an issue with that nerve root, then it can knock out several cutaneous fields, and usually along the pathway of a particular nerve. So this is why a radiculopathy, which is an issue with the nerve root, will usually follow this pattern and go below. In this case, it will go below the knee and into the foot. So when you're kind of differentiating, is it a cutaneous nerve issue? Is it just a weird sensation because of something around this area, or is it likely to be nerve root? If it's nerve root, it will usually knock out a larger area of the skin because there are several cutaneous nerves that are fed by that nerve root. Hopefully that makes sense. So that's something that you can ask in your questioning when someone's, if they've got odd sensations in certain areas. So like this one here, lateral cutaneous nerve of the thigh. Quite often we'll think, oh, that's the femoral nerve, but it could be. There's also dermatome distribution across that area as well. But if it's to a specific region of skin and doesn't really go anywhere else, then it's more likely to be this cutaneous nerve that's impacted. And for the lateral cutaneous nerve, I just realised I'm pointing with my mouse and you can't see my mouse. So the lateral cutaneous nerve here is there's like an entrapment point which is under the inguinal ligament. So that's quite specific for that particular nerve. This one here would be around the gluteal fold, so that it's in this area here. So coming through sacral 2 and 3, and we were looking 2 weeks ago at all of the pelvic floor muscles around this area here. So there could potentially be some kind of entrapment of that nerve around that pelvic floor region. Okay, potentially. And that would just knock out this area here. And again, these aren't really specific. These are generalized regions. There is a lot of overlap with cutaneous fields, and there's a lot of overlap with dermatomes as well. And I do a session on dermatomes. I've done it a couple of times where there are specific points that relate specifically to specific nerve roots. So if they lose sensation in certain areas, you can go, well, pretty much 99% it's that nerve that's been affected. But when there's a kind of a region that's been affected, loss of sensation or whatever it is, odd sensations, then there's overlap. Yeah, so it is pretty difficult to be specific. I think if from what I do and sort of musculoskeletal care, or if you're working in the fitness industry or whatever it is and someone's complaining of that, first things first, you need to do a neurological exam. And if you don't know how to do one of those, then refer to someone that does. And then depending on the results of that neurological exam, you then send them for further investigation if stuff is picked up. Okay, so that would be my kind of triage suggestion to you, depending on what you do for your role. So but I think one of the main things here is that everyone thinks this is, well, sciatica, which it is, because sciatica just means pain down the back of the leg or odd sensations down the back of the leg, and this is an odd sensation down the back of the leg potentially, but it's nothing to do with the sciatic nerve. Yeah, so again, we've got to be careful with the language we use, because often sciatica is used it is a very broad term. It means literally odd sensation or lack of sensation down the back of the leg, and it doesn't necessarily mean that it's coming from the nerve root. There are lots of different reasons, and this could be one of those. So that's your perforating cutaneous, and often people haven't heard that one before. Then we've got some gluteal nerves, which are motor nerves, and we've also got some nerves around the gluteal region that are skin nerves. And these are really, I think, really important for, especially for manual therapy, massage therapy, because we often will get patients coming in where they describe maybe loss of sensation, that kind of dull, achy feeling around the gluteal region. and we don't consider the cutaneous nerves. So that this might help you have a look at those in a bit more detail. So these ones are more these ones are motor nerves. So the gluteal nerves here, I think I've got some videos of these ones. These ones they supply the muscles around this region here. So obviously if these are affected, then these muscles will be affected and they'll test weak. So we've got gluteus medius, gluteus minimus, tensor fasciae lata. So this is the superior gluteal nerve. There's your greater sciatic notch. There's the nerve coming up here, and we know that the medius and minimus attach around this area here. TFL, tensor fasciae lata, around the front over here. So the nerve basically goes to that particular region. And if we've got a superior nerve, we must have an inferior one. And this is the inferior. And again, through that greater sciatic notch, there's the ischial spine, there's the lesser sciatic notch just there. So it's coming through there. And this time it's going a little bit lower, hence inferior. And this one supplies your gluteus maximus muscle. Okay, so just glute max. And you can see, again, the nerve roots for these L5, S1, S2. And then if we go back, this one's a little bit higher, L4, L5, S1, usually. Again, there are some crossovers with nerve roots as well. So let's just have a look at those. Just get rid of that and that. So these are the gluteal nerves. So these are the motor nerves, and then we'll have a look at the sensory nerves around the gluteal region. So different kind of things. So there's your sacral plexus. So nerve roots L4, L5, S1, S2, S3. Piriformis muscles tucked behind there, and that's your sciatic nerve. Okay, so contributions from all of those nerve roots, and then there is your superior gluteal nerve. Just going to pause that, and it looks tiny. Okay, absolutely tiny. You think, is that it? Yeah. So that's the one that because it's superior, it will supply all of those superior gluteal muscles. So your glute medius, glute minimus, and your tensor fasciae lata, TFL. And so that is that one. Literally just that tiny little branch coming off there. And your greater sciatic notch is that region just there. So if we spin this around, there's your glute maximus. And then we'll have a look at the inferior gluteal nerve. So there's your sciatic nerve, there's the piriformis, that's the sciatic nerve coming down there. There she is. And then there's your piriformis muscle, and then there's your inferior gluteal nerve. Just that bit there, yeah? And that's the one that goes to your gluteus maximus. Yeah, and then there's the superior gluteal nerve just there. So a tiny, tiny little nerve there, supplying your gluteus medius, glute minimus, and your tensor fasciae lata, and then inferior gluteal nerve just there for the glute maximus. Yeah, so I don't know what you had in mind for the kind of size of those nerves, but I think they're surprisingly small for the muscles that they innervate. Yeah, so these are the gluteal. These are the muscles that are supplied by the gluteal nerves, and then the inferior gluteal supplies your glute maximus, gluteus maximus. There you go. So those are the ones that we can see, because again, you know, years gone by, we were just interested in the nerves that innervated the muscles. So we're interested in the muscles, and then we started getting more interested in the connective tissue or the fascia that surrounds it, because usually that's just taken off and discarded so that you can get to the muscles. And now we're interested in even more superficial layer, which is that cutaneous nerve layer underneath the skin. So we're getting there. It's I'm sure there'll be something else in years to come. So these are some of the sensory nerves around the pelvis and down into the hip area. And these are really important to know about, I think, because you do get quite a few patients that come in worrying about hernias, so like testicular cancer, that kind of thing, because they're getting odd sensations around the genitalia and into the groin area. And yeah, of course, you should like think of that as your top priority, those red flags, just in case. But if they've been scanned, you've sent them away, they've been imaged, and nothing's come up on the scans. They've had all the blood tests done or whatever they need to do in, and they're all negative as well. And then the patient's then scratching their head. Well, why am I getting these symptoms then? And this could be one of the reasons why. We've got these sensory nerves that come around from the nerve roots around the in the spine. So L1, L2, split into two branches. This one, genital and femoral. And in males, this nerve will innervate something called the cremaster muscle, and we'll talk about that in a second. And then the sensation in males and females is the upper thigh, so around this area here. And then in females, it's the labia majora and the mons pubis. And then in males, it's the anterior part of the scrotum. And if you have a look at the way in which this tracks, it comes down here, and then underneath, kind of, or around the inguinal ligament area, around the skin of that area, and then supplying the skin around here. Okay, so if we think about those images that we had of the psoas and the iliacus, and we were thinking about, pushing into those and accessing those muscles for manual therapy. These are the kind of nerves, as well as the femoral nerve, which lies really close to the psoas. These are the nerves that we could be potentially impacting or irritating, potentially. Okay, so that these need to be considered with pain around this region, sort of into the groin and into the genitalia. And I had a chat with exactly this kind of presentation. Really worried, kind of that age where testicular cancer is prevalent, history of it in his family. So we got him checked out, and everything was clear. But it was still like, well, why is this happening? So we focused on the skin around this sort of inguinal ligament area around here, and by applying treatment to this area, it reproduced his testicular symptoms. Yeah, and it was all around this area here, sort of inguinal ligament region, and it exactly mimicked what he was feeling. So obviously, get all the nasty stuff checked first, and then layer this knowledge in, and have a bit of a play around to see if anything here affects the symptoms. And within a couple of treatments, it had gone. Okay, so but obviously I needed to make sure that it wasn't anything nasty first. But yeah, so that is something to consider. These nerves around here, and we've got. You can see this one here as well, the iliohypogastric. We'll talk about that in a sec, but that is another really common one. Yeah, so symptoms around the iliac crest, and that's a really common area where people complain of. Kind of just, I don't know, just gnawing, kind of achy sort of feeling, and we're thinking, what are the muscles that are underneath there? Potentially it could be some of those. Maybe we need to do some exercises, but actually the cutaneous nerves may be impacted around that area for some reason, and usually they're impacted by some kind of compression. Yeah, so it's just something to think about. Yeah, so it's a good question, that, David. Yeah, because well, I've talked about this quite a bit with in the courses, where, because you'd think that, okay, so this nerve here, so that it comes over here and down here, so you think, right, if I want to kind of reduce the tension in my mind, I need to kind of push that nerve that way. Yeah, so kind of drag the skin and push it back to where it's coming from, just to offload that nerve a little bit. Sometimes that works, sometimes it doesn't. So the way that I do it is go with whatever feels easier for the patient, really. And actually, the direction of the cutaneous nerves didn't seem to matter that much. I tend also to use, which again, I'm very skeptical about stuff, but it does seem to work, is cupping around these areas as well. So just providing a bit of a lift to any regions that are reproducing the symptoms, and then you take the cup off after a little bit, and then kind of palpate it just to see if it's bringing about the symptoms again, and it usually changes. Yeah, so if you're getting a change, then hopefully we can maintain that change for a long period of time. But I mean, this area is a one where you can treat yourself. You can teach people to do it themselves. But it's not pushing deep. It's literally just superficial, because that's where the nerves are. So you kind of scoop them into different directions or lift them up, and that seems to help. Yeah. The thought process behind that is a decompression of those nerves. That's the thought process. Whether that is what is actually happening or not, we don't really know. So this is the cremaster muscle. It basically elevates the testicle. So it is a reflex action, usually tested in infants, where they will just get the end of a patella hammer and just gently brush it on the inner part of the thigh, and then the testicle should draw up, and that's what the cremaster muscle does. Okay, so helps to regulate the temperature of the testes by either bringing them closer or further away from the body. So that's the motor part of that nerve. And then this is the iliohypogastric. So one of the reasons why I showed you that grid, do you remember that, of the abdomen with all the different regions in, is because of the names of some of these nerves are related to those regions. Okay, so this one runs along the iliac crest. So if I just pop that there. So this comes from L1, purely sensory, so it only provides sensation to the skin, and it's the skin above the waistband. And from treatments that I've done in the past, or where people have complained of symptoms in the past, this is a real classic area. Yeah, the iliohypogastric. And then people will say, oh, it's like either top of glute max or QL or maybe lats or whatever. But actually, if it's kind of more superficial and a bit more band-like, it could potentially be some kind of compression of this nerve. And remember, it literally just rests in the skin. That's where it's that's where it is. So and again, if you think about logically, if you wanted to kind of offload this, then you think about pushing the nerve that way. So and we tend to use this like plastic called Dyson on the skin to drag the skin, but you don't have to. You just use a towel. So it's like the old myofascial release type techniques through a towel. And again, the myofascial release techniques from years ago, when I learnt it, it was all about melting fascia. But actually, it's much more probable that we were affecting these cutaneous nerves that were in that superficial tissue, because it's really light technique, and you hold it for nice long periods of time, and it's nice and gentle. Yeah, it's exactly the same as that. Basically, it's those kind of techniques, yeah, it probably was the nerves that we were affecting all this time. It was the software rather than the hardware, as we say. And then we've got this one, ilioinguinal. I think this is a classic one as well for kind of hernia type symptoms. And again, look at the pathway of this. Yeah, that is a common like hotspot for people all around that area there, really sensitive along the iliac crest. And again, we immediately think like it's QL or maybe the obliques or something like that, but or it could be this ilioinguinal as well. Runs underneath the iliohypogastric, so and supplies this this region here. Yeah, so and that the region just around about there, that's where you're likely to get symptoms of either a sportsman's hernia or a hernia. Yeah, for especially in guys. So, but also its sensation to the anterior scrotum and the labia as well. So we've got another cutaneous nerve that supplies that genital region too. So it's, if they've been cleared of everything else, that is a good place to have a bit of a poke and a prod along there, see if there's any areas of sensitivity, seeing if it's reproducing symptoms. It's definitely worth giving it a shot. And then these were the ones that I was talking about with the kind of gluteal symptoms. So we've got nerves called the cluneal nerves. These are the cutaneous nerves of the gluteal region, so the skin overlying the muscles. We looked at the motor nerves before, so we had the superior and inferior gluteal nerves. They supplied the muscles. These ones are more superficial, and they supply sensation to the skin that overlay those muscles. And remember, we were talking about Hilton's law, I think it was last week, where the cutaneous nerves in the skin are directly related to the nerves underneath. They're all connected. They're just literally just branches off that go off and then supply the skin quite often. Sometimes they've got their own nerve root origin. But if you, the thought process is that by touching the skin, you can then modulate the nerves and the information coming from some of the other regions that are connected to that nerve as well. So maybe the muscles, maybe the joints, and that is one of the thought processes, one of the theories about why when we rub the skin, we help with joint pain relief. Yeah, because we're not getting in the joint, but we're accessing the joint via the nervous system. So that's one of the thought processes. And these are your branches. So L1 to L3. This is set, and there are no videos of this one, I'm afraid. So these are the sensory nerves for the top part of the glute, so all around this area here. And again, usually quite a sore area. And one of the reasons I think that massage helps, shockwave helps, cupping helps, blades help. It could be anything that's touching the skin around this area. If someone has odd sensations or achy kind of grumpy region of their glutes, could be these cutaneous nerves that are just irritated, and when they're not happy, they just feed back to your spinal cord saying, I'm not very happy at the moment. And if we can move them around a bit, then we can improve the blood supply to them locally, because that's the other thing. We can't affect blood supply any deeper than about 1 centimetre. It's all in the skin. That's where we can affect blood supply. So anything deeper than that, go for a walk. Yeah, but if we do manual therapy to the skin, we can improve the local circulation in that top centimetre, maybe 2 centimetres. And that's where these reside. And when they don't have a very good blood supply, for whatever reason, they'll get annoyed, and they'll get, as Diane Jacobs puts it, they get cranky. Yeah, so if we can manipulate these nice and gently with whatever technique they prefer, then that may help their symptoms around this area. So this is the kind of posterior buttock area. We've got 3 different branches of these, medial, intermediate, lateral, as they're coming down from the various nerve roots. This is the middle cluneal. So this is coming out from the sacrum this time, so S1 to S3. This is sensory, skin over the gluteus maximus. Yeah. So again, someone might point to that area and say it's their back. Yeah, that's quite common, but it's really close to the sacroiliac joint as well. So again, years gone by, it would be right, our focus is on this joint, but actually we do anything to the skin, it will affect these nerves, which will then feed through into modulating the sensation in that joint as well. Yeah, so we can't really be specific about certain things were affecting everything around that area. And then we've got this inferior branch as well. So this is skin over the inferior part of the buttock, so around the ischial tuberosity. It's a branch of the posterior femoral cutaneous nerve, which we looked at previously. Okay, so that's a branch off of that, which then goes down the back of the leg, if you remember that one around the hamstring area. So those are the cluneal nerves. There they are there in their entirety. Just move me out of the way. So superior cluneal around this area, middle, inferior around the glute fold, and then the posterior femoral cutaneous around this area here, or the perforating cutaneous. And then, this is it with the muscle layers on. Yeah, so again, we think, we're targeting these muscles, and that's what we're taught when we do manual therapy, but there's a whole other layer of sensation in the skin that overlay these muscles that we may be affecting as well. Okay, so it's just something to add into the mix when you're thinking about what to do. So I think this is our last one. We've got the pudendal nerve, and this is a real common nerve to be affected with, especially in cyclists. Okay, so there's kind of entrapment sites that can be an issue, especially for cyclists. So these are the nerve roots. So it's coming out the anterior part of that sacrum, and then it's really close to your piriformis. So there's your piriformis there. There's your sacrospinous ligament. So that's your ischial spine onto the sacrum. There's your sacrotuberous ligament. So from the sacrum to the ischial tuberosity. Again, if these are all new to you, we covered these in the last few weeks. And you can see the pathway of these nerves. So they all come together, go underneath that sacrospinous, and then pop back out again around the obturator area here. And then we've got the something called the Alcock's canal. So it goes through this specific pathway, and then comes out into the genitalia. So this is a classic. If I just pop this here, so the pudendal nerve does not run DMC. This will stick in your mind if you're, my kind of age. If you're approaching 50, then you'll remember run DMC. So this is what the pudendal nerve does, DMC, and that is defecation, micturition, copulation. Okay, so that's what the pudendal nerve is responsible for. So if anybody has any issues with any of these functions, then there may be a problem with the pudendal nerve. But again, these kind of things, these are red flags anyway. Yeah, so if you had anybody reporting any problems with bowel or bladder changes in sexual function, then that's a red flag for cauda equina. So you get that checked out anyway. But it could be a pudendal nerve issue. There are different entrapment sites, and this is what I mean by it being called a cyclist numbness. So if you this is why bikes have the hole in the saddle, in the middle of the saddle, because that's where your pudendal nerve is. It's basically where your undercarriage is, and you're sitting on that seat. It will compress that nerve, and if you cycle for long periods of time, then that nerve can get squished, and it will just knock out the sensation to your genitalia. So your bits will go numb, basically. And that's something that cyclists will often complain of if they've been cycling for long periods of time. So again, that's why cycling shorts are shaped the way they are, to reduce the pressure on the pudendal nerve and stopping that numbness. But there are several areas where it can get trapped. So we've got sciatic notch, the ischial spine, and the that should be sacrospinous ligament. 3A is the obturator internus, and then 3B, obturator internus and piriformis, and then the distal branches of the pudendal nerve, so as it exits to the back of the genitalia. So what could we possibly affect manual therapy wise? Possibly this one. Yeah, there are specialists, men's health, women's health physios that will do internal massage. Okay, so they and there are specific courses to do internal massage for this particular issue. Okay, so if you do have a patient who has this and they're kind of at their wits' end because they don't know what to do, then get them to see a women's or a men's health physio specialist. Okay, because they can play a massive role in helping them ease their symptoms. Okay, so that's your pudendal nerve, kind of finishes off all of the pelvic area. So we had motor supply, sensation, and in the session last week as well, we had some articular branches as well, which go to the hip joint. So yeah, hopefully all that makes sense. What time is it? We've just got a little bit of time. I'm just going to go have a look at the blood supply as well. It should hopefully finish things off. So we've got we've already seen the femoral artery turn into the popliteal artery behind the knee. So quick switch, going into blood supply now. So at the knee, this is what we've seen. And if you remember, there was the adductor hiatus down by the knee, and the femoral artery will come down there, and then it will go through that adductor hiatus to the back of the knee, and then that's the popliteal artery just there. So where does it come from? It comes from here. So this is your descending aorta. It comes literally straight off the heart, straight down, and then it will split. And this is around about the level of the belly button. Okay, so where your umbilicus is, that's usually where the split roughly will occur. And then it will turn into your iliac arteries. Okay, so we've got descending aorta into your iliac arteries. And then if we have a look here, can you see it splits again? Yeah, so we've got a split there and a split there, there and there. And they then turn into external iliac, which is this one, and then internal iliac, which is that one just there. Okay, so what will happen is the areas to be concerned about in terms of pathology is where they split, because you've got high pressure blood coming straight from the heart down to this area here, and because of the split, it will create some turbulence in the blood flow around this area just about here, and you can get plaque build up on the splits, so either here or here. Okay, those are the usual places. And if those area, it's like you know, when you get go back to geography in school, and you'll have deposits of sediment around the corners in rivers as they start to sweep around, and in a fast flowing area there's nothing, but where it slows down and it goes around a corner, you'll have more sediment. If you have increased cholesterol level in your blood, then that acts like a sediment, so it will start to lay down in these areas where it has to go around corners, and if it builds up, then it will start to close down that space. And what can happen around here is something quite nasty called a triple A. It's an abdominal aortic aneurysm. And what will happen is as the blood is being pushed down here, the descending aorta, if these areas here start to narrow, then the blood pressure will be a lot higher behind those narrow points. So it's like squeezing a hose pipe and trying to get the water through. So what then can happen is the blood vessel expands, okay? And you'll get this bulging of the vessel around this area here, and that's the aneurysm. So the abdominal aortic aneurysm is where you get this increase in expansion of the descending aorta just before it splits. Now, this area here, the nociception around this area is from the organs around the blood supply. So when it gets to a certain size, the aneurysm, it can press on some of the other structures around this region, And it's only when it gets to that point that it starts to ache and you'll get backache. Okay, so this presentation, this kind of thing, is classic for someone who's in their 50s, 60s. I was going to say, blimey, I'm nearly there. And overweight, smoker, you know, maybe history of cardiovascular disease. They're not in very good health. And then they're coming in with back pain, and it's not mechanical. So it doesn't matter which direction they move in, doesn't really change. And it's if it's to do with this, it's because it doesn't matter what position you go into, that isn't going to change. So the sensation will always be there. It'll be there in the morning, it'll be there in the night. Doesn't matter what you do. Okay, so again, red flag. That's something that needs to be checked out straight away. Okay, so that is something that is a significant clinical issue. So yeah, anybody that kind of age, that kind of profile, with those kind of symptoms, then I'd get them checked out, get them off to their GP. Okay, so that's where the abdominal aorta splits into your common iliac arteries. And then this area here, or this vessel here, this is where we've seen before, because that is then the femoral artery, that one there. And then that turns into the popliteal artery. So it's exactly the same vessel. It's just called a different name depending on where it is. So here we go. So blood supply coming down. So we've got the femoral artery around this area here. And then the femoral artery splits as well. So we've got a deep femoral medial circumflex, so this is coming around the top part of the hip, and then a lateral circumflex coming around the lateral part of the hip. So these supply the hip joint around this area here. Okay, and then we've got the deep blood supply here, and then yeah, so it's those are all branches off of that original external iliac. Okay, let me just see if I don't know whether I've got, or I have. Let me just see if that's working. I don't think these videos are working. No, I haven't got that one. Cool. So we'll do a quick recap on that next week. I wasn't expecting to get that far today, so I haven't queued those up. But yeah, that's those. Let me just get rid of that. Perfect. There we go. 2025 done. Another year older. So next week, I'll just do a quick recap on those blood vessels around the hip. I'll get those videos queued up for you, and then we'll move into the lumbar spine and the sacrum. So we'll do that kind of region, and then have a look at all the muscles. Remember, I was saying about think of things like in bands. So if someone, the abdominal aortic aneurysm is a classic example. So if someone's coming in with back pain, then you kind of take a chunk of their body through like that. You go, right, what is in that zone all the way through their body? So we've got all of the musculature and vertebra. Then what have we got then deep to that? What have we then got in terms superficial to that as well? So maybe the cutaneous nerves. So we go cutaneous nerves into the muscles, into the organs. Yeah, so you go through those layers in your thought process about what may be causing the symptoms. Okay, cool. Thank you, David. Will do. Yeah, I've got a couple of days of work in clinic this week, but yeah, New Year's Day off, which is good. So I will see you now in 2026. See you then.